This is a very interesting ECG which shows very classical findings of inferior wall MI. So we need to remember one thing, that whenever we call it as MI, we need to understand that the ECG changes must be present in at least two consecutive leads. So two consecutive leads must show changes. So when we are talking about chest leads means the leads from V1 to V6. So it should show ST elevation of more than 2 millimeter, and if it is limb lead, we can consider ST elevation of more than 1 millimeter as well. But it has to be two consecutive leads. The other things which we need to remember is we have to see the consecutive leads. Consecutive leads means lead 1, lead AVL, lead V4 to V6, these are called consecutive leads. Lead 2, 3, AVF, these are called inferior wall leads, or these are three consecutive leads. And a lead V1 to V4 can be considered anterior leads. So when we are talking about V1 to V4, we are talking about left anterior descending artery. When we are talking about lead 2, 3 AVF, we are talking about RCA, right coronary artery. And when we are talking about 1 AVL V4 to V6, then we are commonly talking about LCX artery. So these are the arteries which are usually commonly involved. So what we need to see is ST elevation in patient with STEMI. So anyone presenting with chest pain and ECG like this, we need to see that whether there is ST elevation or not. So in this, whenever we need to see elevation, we need to see a baseline. So we need to find that the baseline is here, right? So this is what is a running baseline. For example, we can see that this is the running baseline. So if we see here, as we know that this is a running baseline. So basically, this is a Q wave. Q wave is the first negative wave after P. So this is P. We can very nicely make out, I know, this is P, this is P, and the first negative wave after P is Q wave. So this is Q, this is Q, this is Q, this is Q. Then the first positive wave after P is R. So this is R, this is R. And the second negative wave after P wave is S. So this was the beginning of S wave. This was the beginning of S wave. So in short, this is S wave. This is S. So before having this drop in S wave, it was elevated. So this is ST elevation. So this is all ST elevation, because S is starting from here. So this is all ST elevation. So we have to count how much ST elevation the patient is having. So we can see the small boxes. So this is baseline. This is 1, 2, 3, 4, 5, 6, 7. So 7 millimeter ST elevation. 1, 2, 3, 4, 5, 6, 7. So as per rule, more than 2 uh, millimeters of escalation in chest leads, or even in 1 millimeter escalation in limb leads, can be considered MI. In this case, it is more than 5. So this is STEMI. You can see that the escalation is around 3 to 4 millimeter here. So escalation is here, escalation is in lead 3, as well as escalation is present in ABF. So whenever we are talking about MI, in any patient presenting with chest pain, shortness of breath, usually very commonly you can get reciprocal changes, means ST depression. So this is a baseline, this is running, and at the same time you can see that the ST has dropped markedly by around 4 to 5 millimeter. So these reciprocal changes will be seen in the opposite area of the infarcted area. So this is inferior wall MI. This is basically inferior wall MI, and you'll be seeing the reciprocal changes in anterior leads or lateral leads. So in this you can see the ST depression in lateral walls. So this the ST depression. These are called reciprocal changes or revert changes or reciprocal changes. So lead 1, lead 2, lead AVN is showing reciprocal changes, as well as uh, lead V6 is also showing the reciprocal changes. So this is very typical ECG showing ST elevation, reciprocal changes, and the ST elevation is persistent in lead 2, 3 AV, means it is inferior wall MI. So to diagnose it as MI, you just need three things out of two things. The first thing, patient should have typical chest pain that should be in the center of chest, or the chest pain which is related to left upper extremity or right upper extremity or towards the jaw. It should be excruciating, or it should be very severe in pain. Very commonly, diaphoresis or extensive sweating is present. This is very typical symptom of uh, myocardial infarction. Very commonly, patient may have shortness of breath, breathlessness. This is also called angina equivalent or chest pain equivalent. The second thing, the patient ECG should these changes. So ECG changes if it is present, and the third thing is patient should have positive cardiac markers which are positive. So positive by cardiac markers means troponin I, troponin T, and very commonly CKMB, that is creatinine kinase, that is myocardial specific. If these are positive in titers, and if patient has chest pain, we can call that the patient has acute coronary event or myocardial infarction. And this myocardial infarction, if it is present with the ST elevation, we call it as STEMI. When myocardial infarction is present in absence of ST elevation, we call it as N-STEMI, that is non-ST elevation MI. So in this case, ST elevation is there, means it is STEMI. And the treatment is obviously PCI, that is primary coronary intervention, or PTCA, plasty. We have to do the angioplasty to the culprit vessel with drug-eluting stents, depending on the extent of involvement of the artery. And if PTC is not possible, or if it is not available at that particular center, then we always go for thrombolysis with the newer agents. So in thrombolysis, the most commonly preferred is tenecteplase, which is given over a period of 5 seconds. It is the MI is thrombolized with tenecteplase over a period of 5 seconds. Or if the patient is poor, it can be done with STK, injection streptokinase, 1.5 millionunit or 1 hour. But we have to remember that STK is very antigenic. Hypotension is very common with STK, especially if it is not dissolved properly, or especially if it is given in concentrated dose, or if it is given fast. So it has to be given over a period of 1 hour, otherwise patient may have hypotension and patient may die before getting thrombolized. So that's all for today's topic. We'll meet in the next topic.